criteria. So on that checklist that I just gave you with the lab practical is the same criteria that is outlined extensively in week 2. It's not any different. It's just formatted differently because it's on the practical checklist as opposed to the online content. You also have it listed out for you in the E1 manual on page 70 page? No, 60 something. Oh, here, 69. Criteria for manipulation. So it's listed there for you. It's listed in week 2 for you. It's listed in our lab objectives for today. You've got it out all sorts of different places, which is how important it is. Okay? Every time you do a manipulation, regardless of the body part, you need to be thinking through these criteria in your head. Okay? On a practical, you can say them out loud if you want to. That's fine. You can say it in your head. It doesn't matter to me as long as you do it. Okay? So the first one starts off with our patient position. We are doing a finger. We're doing the MCP, which you have a picture or a video of under the lab videos. MCP distraction and MCP AP and PA glides are what we're going to do today. It is also in the E1 manual on page 74 and 75. All right, so again, you've got it in multiple locations. So first thing we're going to do is patient position. So Amanda is seated. I'm going to have her hand on the wedge. We're doing the MCP, so I'm going to have her positioned so that her metacarpal is on the wedge, but her finger is off and the MCP joint is off the wedge. The wedge is helping to provide stabilization and support and putting her into a good position so that I can get at the MCP joint. Therapist position. I am seated at a 90-degree angle to her. So that's going to allow me to get at this finger and work on it appropriately. I'm not here because then I'm not going to be able to position myself the way I need. My direction of force and everything is going to be off. I'm definitely not sitting in front of her. She is not back so far that the table is going to get in my way. All right, so she's at the edge. We're at a 90-degree angle to each other on this one. So patient position, therapist position. Loose pack position. We talked about what loose pack position is. It is where everything is on the most amount of slack, right? So muscles are on slack, tendons are on slack, ligaments are on slack, capsules on slack, everything is on slack. So there's the most amount of space available. Dead man float. Okay? With the finger, it's typically where they're going to rest. Just slide it just a smidge. It's typically wherever she's going to rest, but I'm going to take her through the range of motion to feel where the loose pack position is. As I bring her into extension, I feel tension on the palmar surface of her finger. As I take her into more flexion, there's more tension on the dorsal surface. I want to gradually narrow down that range or that position to where I don't feel tension on the palmar surface or the dorsal surface. It feels like it's in a natural position, which is right about there, which is where she was resting when she just let her hand relax. For the most part. Okay? It might be a little bit less or different on different people, which is why you need to feel it. So we can't say it's always going to be 20 degrees because it's going to be different on different body types and different people. Loose pack position is an angular position. That means I can take a goniometer out and I can measure what her loose pack position is if I wanted to. I'm not going to, but I could. It could be different every time she comes in to see me, which is why I need to have a feel for where is that loose pack position. That's why I'm not always going to say it's 20 degrees, because she sees me today and we find it's here. I do some work on her finger, it loosens up, it improves, she's got more motion. Tomorrow when she comes back to see me, or 2 days, her could be in a slightly different position because now she's got more motion. Things have changed, the structures and the tissue have changed around her finger. Okay, so we're not going to say it's always going to be this one position. We're going to go by what it feels like. Okay, so take her into some extension, tension on the palmar surface, take her into flexion, tension on the dorsal surface, narrow that down. Okay, so that's her loose pack position. The next one is palpation for alignment. When I palpate for alignment, I am looking at articular alignment. Okay, articular meaning joint. I'm looking at the joint surfaces. I want the joint surfaces to be lined up appropriately. Okay, So as I palpate across, I'm looking for, does it feel the same on the medial and lateral sides? I can't really feel the palmar and dorsal sides just because there's tendons in the way, it's not going to work. So the MCP, I'm looking at the the medial and lateral sides of the joint, and I'm just looking for, does it feel symmetrical? Does it feel the same? Or does it feel like her phalanx is shifted off to one side? Or is her phalanx shifted up on the dorsal, or is it shifted palmar? So does it feel like it should, which as you do more, you're going to be like, I don't know what it's supposed to feel like. It's the first time I've done this. Well, as you do more, you'll realize what it should be, like what it should feel like. But again, this is where your anatomy comes in. You have to be able to visualize that joint. What should the MCP joint look like? It ends with the metacarpal is the convex surface. You've got the proximal phalanx is the concave surface. What should those relatively look like based on your cadavers from the first semester? You know, the models that you guys have, anatomy drawings and pictures. So what should it look like? And I really, when I manipulate any joint, I visualize in my mind, what does that look like? What are the bony surfaces? Should they look like? Where are they lined up? And how is that joint going to move, or how should that joint move? Okay, so the palpation for alignment is feeling across the joint, but it's also you using your anatomy knowledge to know, does it kind of feel like it should? Because it should be the same. I mean, I feel a joint line right here on the radial side, and there should be a joint line, right? Because the bones aren't smack dab right up against each other. There's a little bit of space there. But I feel like as I come off the metacarpal, there's the metacarpal, there's the joint line, and then I go to her phalanx, it's kind of in a line. Like her phalanx isn't shifted one way or the other. There's no steps or deviations. It feels normal, okay? Same thing when I go off the medial side. Here's her, okay, there it is. There's her metacarpal, there's the joint line, there's the phalanx, okay? And it feels the same on both sides. Like I don't feel more phalanx on one side versus the other. I don't feel more metacarpal on one side versus the other. It feels symmetrical. Okay, that's my palpation for alignment. Yeah, you're good. Okay. So I need to do that. If her joint was not lined up appropriately, I would need to position it so that it had normal and neutral alignment before I started any manipulation. Okay. We're lucky Amanda has a normal finger. We're good to go. We don't have to do anything. Okay. So that is palpation for alignment. Then I come to stabilizing hand. My stabilizing hand is going to come onto the metacarpal, and I'm going to grasp the metacarpal between the finger and my thumb, and I'm holding it on the palmar and the dorsal surfaces. My manipulating hand is going to go onto the phalanx. My thumb is on the dorsal surface. My index finger is slightly flexed on the palmar surface. So I've kind of got almost like a hook, or lateral key grip, sorry, not a hook grip, a lateral key grip to hold the phalanx. Okay. Now, my contacts for both my stabilizing hand and my manipulating hand need to be close to the joint line, but I'm not blocking the joint line, and they're not on top of each other as far as my fingers. So I want to be at the joint line, but not blocking it. Okay, so stabilizing hand, manipulating hand. Now, my other thumb, or my other finger, sorry, can come around her thumb, or it can come between. I could come around her thumb with my finger. Okay, so I went between her thumb and her finger. I can do that, or I can come around. It doesn't matter. It's whatever works better for you based on your hand size and your partner's hand size. There's going to be some hands that you're not going to be able to come all the way around. You're going to have to go between the thumb and the finger. Okay. There will be some where your hand is just not big enough to get at it no matter what you're doing. So in which case you can use your whole hand on top of the metacarpals to hold the metacarpals into the wedge to provide your stabilization. You could even do that even if your hand does fit all the way around. I personally don't like it. I mean, I'm not saying it's wrong. You can do it. Nothing wrong with it. I don't like it as myself as a therapist because I can't feel what's happening at the joint as well or as good. When I have two hands on there, I have much more input as far as what's happening at the joint because I feel stuff from my stabilizing hand and I feel things from my manipulating hand. All right, so I want to be able to have that input from myself from both of my hands. When I do this and stabilize over top, I lose all that proprioceptive input from my stabilizing hand. So you can, there's nothing wrong with doing it that way. It's just I personally don't like doing it. What do you do?
No, I like to hold.
Hold, like I was doing first time?
Yeah.
So.
I like to, the more control I have, the better.
Yeah, yeah, and I feel like I've got more control. When I'm this way, I feel like I'm not in as much control, and I like to have control. In more ways than one, right? Not just with my fingers. So, stabilizing hand, manipulating hand. So I'm close, but I'm not blocking the joint. I am then going to bunch the skin a little bit. That's not one of your criteria on there, but I want to see a little bit of a skin bunch because I need to create a little bit more slack in the skin. And we'll show you why here in a minute. We'll do it both ways, without a skin bunch and with a skin bunch. So I'm going to bunch the skin a little bit so that I've got some skin slack. Because if we think about our end feels, is skin an end feel?
No.
No, right? So I don't want the skin stopping me. I want to see what's actually happening at the joint itself. And if the skin stops me, I can't do that, okay? So stabilizing hand, manipulating hand, direction of force. Okay, my direction of force I'm doing a distraction, sorry. I'm going to distract. So where does my direction of force need to be? Perpendicular to what? Okay, which side of the joint is concave? The phalanx. Okay, so the distal part of the joint, the proximal phalanx is the distal part of the joint. So that's my concave surface. Now, she's in a loose pack position. So the concave surface isn't straight up and down. If she was straight out, can you hold your finger there for a second?
Yep.
If she was straight out, then her direction of her concave surface, the direction of my treatment plane would be right here, straight up and down. So to be perpendicular, I would need to be straight out. She's in a loose pack position. Her concave surface has moved, right? So now instead of being straight up and down, it's slightly at an angle. I need to be perpendicular to that. So that means my direction of force needs to be down on a diagonal. It's not straight out, it's down on a diagonal in order to get the true direction of force to be perpendicular to the concave surface. Okay? So, again, you need to know your anatomy so you know which side of the joint is concave, but then you also have to be able to visualize where that joint surface is once it changes. If she was straight, it'd be here, but she's flexed, so it changes where that concave surface is. Okay, so you have to be able to visualize that as well. Okay, so my direction of force is going to be here, and then my last one is the amount of force, which is I'm going to doing it for an examination. All right, so I'm going to manipulate for examination. So if I'm manipulating for examination, how far do I go? How far do I pull? Until I feel an end range. Yep, exactly. So I'm going to pull until I feel an end range. So I bunch the skin, my hands are close together, my forearm is down. I am pulling down with my forearm. So I'm pulling back like that. I mean, that's way exaggerated. She's not going to have that much movement. There's a good amount here, but not that much. So I'm here.
And this is joint play.
This is a joint play, yes. Why is this a joint play?
It's a distraction.
Okay, but true. But why is a distraction a joint play?
Because it's outside of normal joint.
It's out of
Involuntary movement.
outside of joint movements because it's involuntary. Can you make your joint distract?
No.
No. I need to come in here and I need to pull on it in order to create a distraction. So a joint play is created by an outside force. Okay? So a distraction will always be a joint play, but a joint play will not always be a distraction. Because there are other options of joint plays besides a distraction.
Such as?
Such as tilts.
That we haven't learned.
I've heard of them, right? I've heard of them.